Today I'm not share the recording, okay? Yeah, because that's why I told you the doctors to join. But still 10 doctors. Yeah, let's see. It's fine. We will start the discussion. Okay. So we will quickly discuss. This is not theory class, okay? Please remember, because of that we are just revise it, right? We are just quickly go through these topics. We are not taking too much time because we already have discussed this theory part in our theory sessions, and all the videos you can find in YouTube. Okay, so we'll start. Okay. Yeah, we'll start from what? We'll start from asthma, right? Asthma also we have what? We have acute management and we have maintenance treatment for the asthma, right? So first we will discuss about acute management, right? Okay, here. In acute management also you should know. So now I'm not going to discuss about what is acute asthma like that, okay? Because today's that's not the time for that, right? Okay. In acute cases, acute asthma management. So, what do you know about it? But okay, if the patient is presenting with acute asthma, and if you are suspicious of there can be anaphylaxis, what you should do? Like every day, I'm telling this thing. If you are not sure about, yeah, if you are not sure, sorry, if you are not sure about this anaphylaxis or asthma, always treat it as anaphylaxis, right? Because the anaphylaxis is the most life-threatening event. Asthma also life-threatening, but if there is anaphylaxis and you are not sure about it, treat it as anaphylaxis. Okay, yeah. Remember this thing in your mind. Okay, good. Yes. Okay, doctor. So, in acute asthma management, also, you should know uh, there is a first aid for acute asthma, because usually this asthma patient has their own action plan, right? Their own action plan. So, like in this action plan, the doctor has given the stepwise approach. If there is an acute presentation present in their home or the community setting, right? So, what is the first aid management for asthma? This is not the hospital management. This is acute management, or we can call it first aid in the community setting, right? Community setting. So, what is it? What is it, doctors? We have to follow what 444 rule. It's the first aid plan, right? First aid plan. So, what is the first aid plan for this one? Sorry, you have to follow this 4 by 4 by 4 rule, right? That means what? Salbutamol 100 micrograms per actuation, 4 actuation, 1 at a time via PMDI. And here, repeat after 4 minutes if required. And here, the with spacer if available, taking 4 breaths from the spacer after each actuation. So, and you have to repeat 4 minutes if required. If still no response, you have to call the ambulance and continue this giving 4 activations here, or up to 8 activation in adults every 4 minutes. So that's why we call it 4 by 4 by 4 rule, because like everything is mentioned in multiple of 4, right? So here for activation, repeat after 4 minutes, and here again we can continue if the patient is still not relieving, and we after calling ambulance also we can continue every 4 minutes, right? Yeah. So if salbutamol is not immediately available, what are the other options that we can give? We can write down in the action plan as a first aid. We can use terbutaline or budesonide formoterol. Okay, so remember these two as well. So these are not like I have not seen like they're asking from this first aid part, like according to the asthma plan, but they are asking from the hospital setting, right? So here in acute asthma management, we have what? First of all, we have to do the Okay, if the patient is presenting with this acute asthma, and first of all, what you should do, you should remember these things. I have, yes, you have to do the immediate severity assessment, right? Immediate severity assessment or rapid severity assessment, because we have the two severity assessment, right? We have uh, sorry, immediate severity assessment, and we have secondary severity assessment as well, right? Hope you remember everything. So first thing is rapid or immediate severity assessment, right? Immediate severity assessment. Okay, this is the therapeutic guideline, and I will show. This is the asthma handbook. Okay, because all these two are kind of same. Okay, like structure and everything different, but there's a small difference. In last class also I have explained. I will explain it again when we discuss about the maintenance therapy. Okay, like for the acute asthma, almost it's like a same. Okay, here I think this is easy to remember. Easy to remember than this one. This one also not bad, okay? Because here they have given here the immediate treatment according to the immediate severity assessment, right? So mild to moderate severity mean all of here can walk, speak whole sentence in one breath, and SpO2 more than 94%. So in that case, this is the mild to moderate severity, right? Mild to moderate severity. So how you should manage these patients, doctors? Mild to moderate one. The same thing, okay, I'll show, because some doctors are thinking these are different. Here initial rapid severity assessment same, can walk and speak whole sentence in one breath, SpO2 more than 94%, right? Here all of following should be there. The same thing, doctor, okay? That's why I'm telling, don't confuse, okay, those two things. And here what they have mentioned, mild to moderate, give salbutamol via PMDI with spacer, right? Here also give salbutamol 1 to 12 octavation via PFD and spacer. Same thing, okay? So let's discuss how severe form is present in any of unable to complete sentence in one breath due to breathlessness, use of accessory muscles of neck or intercostal muscle, tracheal tuck, subcostal recession or during inspiration, obvious respiratory distress, obvious respiratory distress, and SpO2 less than 94%, less than or equal to 94%, right? Oh, then how you should treat these patients? Anyway, you have to arrange for the acute care, right? You have to uh, admit these patients to the acute care. And then what you should do, give salbutamol. Here, give salbutamol 12 actuations via PMDI and spacer. Then if patient cannot use a spacer, 5 milligram salbutamol nebulized via nebulizer, right? And then start oxygen supplementation if SpO2 less than 92, right? The target SpO2 is 92 to 96%, right? Good doctor. Good doctor, Aruna. Yeah, you remember it. If life threatening, how it present any of follow. So reduce consciousness, collapse, exhaustion, cyanosis, poor respiratory effort, SpO2 less than 92 here, less than 94. Okay, less than or equal to 94 here, less than 92. Poor respiratory effort, soft absent breath sound. So anyway, we have to transfer for the acute care management. And here, without nebulizer, give salbutamol 12 actuation via PMDI and space with or without mask. So with nebulizer, give salbutamol 2 to 5 milligrams nebulized via continuous nebulization driven by oxygen, SpO2 target 92 to 96. The same thing, doctor. Here, that as teaching. Okay. Then what you should do? Okay, then what you should do, doctor? See, we'll discuss from here. Okay, so that is rapid severity assessment and rapid treatment has that. Then what you should do? Then within minutes, perform a more detailed secondary severity assessment. So tell me, what is secondary severity assessment, doctor? Secondary severity assessment. Okay, here. Yeah, this is the secondary severity assessment. Okay, here also I will show. Just 1 minute. There's another chart here. Okay, this is immediate assessment. Where's that part? Hmm, I don't know why I can't find it. Okay, don't worry. I have the downloaded one. Secondary severity assessment. It should be there like this. This is immediate one. Yes. Here. Sorry, doctor. Here. So this is the secondary severity assessment. After stabilizing the patient, after done the immediate treatment, then you have to do the secondary severe assessment. So what is secondary severe assessment? So you are checking consciousness, speech, posture, breathing, skin color, respiratory rate, heart rate, chest auscultation, and oxygen saturation. Uh, in this case, the secondary one, you are doing the secondary assessment, right? So in mild to moderate, all of consciousness alert, speech can finish sentence in one breath, posture can walk, sit upright, life at, breathe in, respiratory distress is not severe, skin color normal, respiratory rate less than 25, heart rate less than 110, chest auscultation, wheeze or normal lung sound, oxygen saturation more than 96. So severe cases here, uh, consciousness not applicable. It can depend, right? So speech can only speak few words in one breath, unable to lie flat due to dyspnea, sitting hunched forward, paradoxical chest wall movement, inward movement on the inspiration and outward movement on expiration, chest sucked in when person breathes in. Okay, like that. Or use of accessory muscles of neck or intercostal muscle and tracheal tuck can be seen. Subcostal recession also can be seen, or we call it abdominal breathing, right? So respiratory rate more than 25, heart rate more than 110, oxygen saturation it can be 92 to 96% between. So life threatening here any of consciousness, drowsy, unconscious or collapsed. Here cannot speak, posture collapsed or exhausted, severe respiratory distress. So poor respiratory effort, skin color is cyanosed, bradypnea, then cardiac arrhythmia, bradycardia, then silent chest or reduced air entry, oxygen saturation less than 92, or clinical cyanosis, right? This is the secondary assessment. This is the easy one. This is the easier chart. Yeah. Then, so let's discuss after what we can do here. Okay. Within minutes, perform more detailed secondary severity assessment. So repeat severity assessment frequently within first hour. Example after each dose of inhaled salbutamol. So mild to moderate, repeat salbutamol dose as needed. We have to continue the treatment. If it is severe, repeat salbutamol and ipratropium every 20 minutes or sooner if needed for the first hour. In here, but we are repeating salbutamol and ipratropium right here. And one more thing, in this case, the acute asthma here they have added ipratropium as well. Okay, but as this Australian asthma one, they have not mentioned about in severe cases. Yeah, they have not mentioned about this ipratropium. Right, so here not mentioned about ipratropium. So just keep those things in mind. Okay. Yeah, because we have to follow TG and both are the Australian guidelines. So, like when you are doing the questions, you will understand, right? Just keep this in mind. Here they can add uh, ipratropium as well. Okay. Yeah, then here, if the severity is still present in after secondary assessment as well, so we have to repeat this salbutamol ipratropium every 20 minutes for the first hour. If continued insufficient response, arrange transfer to hospital in primary care. So life-threatening continue nebulized salbutamol and ipratropium. Okay. So what is extra point in TG? Like almost everything same, but they have added ipratropium for the salbutamol. Okay. Yeah. Then, as soon as practical and at least within the first hour, give oral corticosteroid therapy for all adults and children 6 years or older, or children 1 to 5 years, unless the child has only mild moderate disease that respond to initial bronchodilator treatment. So then continuously reassess the severity and response to the treatment. If symptoms resolve, treatment can be stepped down or stopped. Okay, stopped. Observe patient for at least 1 hour after symptoms resolve. If symptoms persist, arrange transfer and admission to hospital. Continue monitoring and bronchodilator treatment. If severe or life-threatening asthma persists, arrange transfer and admission to the critical care facility and seek urgent specialist advice about additional treatment. Right? Hope you understand it. So the same thing, you can just give it a rate. Yeah. Actually, they have added with ipratropium as well with salbutamol. So keep those things in your mind. Okay. Okay. Let's see here. I think here also. Let's see, because for the other treatment management, I think they have added these things after the secondary assessment. Let's see. Mhm. Okay. Not mentioned about it here. Yeah, they have mentioned about this ICSL lava. Okay, it's fine. Just keep those things in the mind. Okay, I think everyone has done the like e-medicine questions, right? For asthma, I think there are some 28 or 29 questions. So if you haven't done, please go and check, because you can learn so many things. Last time also when we were doing the theory class, we have done like we got so many things from this question answer. So the next one is asthma. What next one is asthma maintenance management. So maintenance management, actually better to use this chart. It's very easier to understand, the handbook chart. And there's another chart in therapeutic guideline. Okay, there's a therapeutic guideline. I will explain what is the difference between these two. Okay, so okay, before that, tell me what is asthma maintenance treatment mean? What is maintenance treatment? Why we are giving maintenance treatment, and what are the components that can see in maintenance treatment? Tell me what are the things included in here? Yes, to reduce the exacerbation, right? To reduce the acute cases of asthma, right? For that, what we are giving? In the maintenance treatment, we are giving what? We are giving relievers and preventers, right? So what are the relievers, doctors? So what are the relievers? Oh, sorry, what happened? Yes. So what are the relievers? Relievers is the one, like name you can understand, right? It give quick relief to the symptoms, right? So symptoms we all know: breathlessness, wheeze, chest tightening, right? Yeah. What they are doing? They dilate the airway, right? They open the airway and ease the symptoms, right? So what are the example? What are the drugs that can use as the use as these relievers? Use as relievers, doctors. Give me example. Mm-hmm. Okay, salbutamol, terbutaline, right? Yeah, and ipratropium as well. So yeah. Now tell me, what are the preventers? So what is the function of preventers? What are the function of preventers? We are using preventers to what? Control the disease and reduce future symptoms or attack. It reduces the symptoms and the frequency of attacks, right? Yeah. So what is the main preventer that we are using? What is the main preventers? Inhaled corticosteroid, right? Inhaled corticosteroid, right, doctors? Yeah. Okay, so let's discuss. In maintenance therapy, so you all know what we are doing, right? We are giving preventers and relievers, right? To maintain their symptoms and to maintain their symptoms and what? To prevent the exacerbations, right? What is in the chat? For acute cases, we will use, yeah, doctor. So what is the reason of using relievers? To give a quick relief to symptoms, right? So acute cases, patient present with shortness of breath, wheezing, right? So we need to give something to relieve these symptoms. So in acute cases, we all, like most of the cases, we are giving, not most of the cases, every cases we initiate with the relievers. Okay, relievers, yes, like pain relief. Yeah, doctor, you are correct. Okay, so let's discuss about maintenance therapy. So I'm not gonna discuss about diagnosis and everything. So you should know about asthma severity classification, right, according to the symptoms. So we have intermediate, we have mild, we have moderate, and we have severe. So symptoms, if it is less than 2 days per week, or night awakening less than 2 days per month, or use SABA less than 2 days per week, less than or equal to 2 days. Okay, everything. So just we can we can consider it as an intermediate one. So what is mild? Mild means symptoms less than or equal to 2 days week, but not daily. Here, night awakening 3 to 4 times month. So use of sabah more than 2 days week, 2 days per week, but not daily. So like that. Okay. I know everyone know about this chart, and like you don't need to remember everything, doctors. You don't need to remember everything. Just I will show what are the like specific symptoms you should remember, because here, okay, this is the chart they have given in the asthma handbook, and this is the easiest chart. Okay, and here they have given like a huge chart that mentioning everything, but this chart is not wrong. Okay, this chart also like explaining everything properly, but the only part that they also, when we discussing the theory also, I explained here. In step one, they have mentioned as required Saba or as required ICS plus formaldehyde. But nowadays in Australia, we are not recommending the Saba for this one, right? We are just recommending what? We are just recommending this ICS plus formoterol as the initial step, right? We have done that emergency question as well when we were doing the theory, and I explained during our theory session as well. Okay, that's the part here they are mentioned. They are like changing, but here also same, they have mentioned, but always go with ICS plus formoterol. So what is the best example I told you to remember in that day also as BF, right? So what is your who is your BF doctor for AMC? Yes, budesonide formoterol, right? So remember. Yes, budesonide formoterol. This is the best drug that we can initiate, right? Yeah. Remember, as your AMC's BF, right? Yeah. That day also I told the same thing. Yeah, doctor. Yeah. You should remember if you were in my theory class, right? Yeah, BF. Remember, BF always comes first, okay? Not in real life. I mean in AMC for asthma. Maintenance management, right? Yeah. Okay. So we'll discuss from here because I have explained that the huge chart in our theory class, but now you need something short and sweet, right? You need something short and sweet. So better we follow this chart. Okay, here for a suitable initial and long-term treatment for most patients. So what? First lines, budesonide formoterol. One more thing. So what is these two here? The right side and left side you can see in here. So what are those two types, doctors? Why they have given two things separately? Why? Tell me. So what is in right side and what is in left side? Tell me. Why, doctors? Mm-hmm. Yes. So the left side, okay. So this side is the recommended side. Left side is the recommended side, and this is the alternative side, okay. This is the alternative side, and this is the recommended side. So remember. And here, okay. Now tell me what is the MART? MART mean what? So what does mean this SMART therapy? MART. So what is this SMART? Like before we going through this one, you should know this term. So what is SMART? Tell me, doctors, what is SMART? So what is SMART therapy? What is it? Yes, good. Yeah. MART mean, okay, MART mean, okay, here we use SMART for what actually? Maintenance reliever. Okay, good. MART mean maintenance and reliever therapy. Now tell me why we are using MART? What is the reason of that? Okay, here. So the main reason in MART therapy, MART mean the mhm, both reliever, both reliever and reliever and preventer in one inhaler, right? Preventer and reliever in one inhaler. That means what? So instead of using two inhalers, like for preventer one inhaler, like corticosteroid inhaler, and sorry, inhale corticosteroid inhaler for preventers, and the reliever inhaler as a salbutamol inhaler. Instead of using two of these, we are using one inhaler for both purposes. So the best example is budesonide formoterol, right? Yeah, budesonide formoterol, the BF. Okay. Mm-hmm. Yeah, doctor. And this is easy to use, right? Easy to use, right? So how we use this MART, this one inhaler. So maintenance dose we have to use every day, right? And so reliever dose when symptoms occur, right, doctors? When symptoms occur, right? Yeah, we have to maintain the dose, and even there is some acute case or exacerbation occur, then we have to use this reliever dose, right? Like that, it's like using. Okay, so yeah, what is the advantages are? It's like better to use, right? And we can reduce the asthma attack in. It's very easy to use, the main thing, because it has one inhaler, right? Okay, like that. In this one, okay, in here in TG, they have mentioned everything inside this smart therapy, like that. Okay, here regular daily dose of ICS plus LABA plus as required supper. They have not mentioned it as the smart therapy. That's why it seems like very complicated. But like when we smoothly consider it, almost the same. Okay, the things they have mentioned in here. Okay, plus as required sabha. That means always remember about this smart therapy. I'm recommending you to follow this chart. Okay, it's very easy. Okay, let's see. Okay, so here as the first thing we can use suitable initial and long term treatment for most patients. So budesonide formoterol. So here we are using it as low dose, right? Low dose as needed. Low dose as needed. So why we should step up? Why? Consider starting at level 2 or 3 if frequent or severe symptoms or higher risk of exacerbation, right? Symptoms and risk of exacerbation is increased, we have to step up, right? So what? ICS formoterol, ICS formoterol maintenance and reliever therapy. Here also low dose, right? Low dose. Okay, here I'll explain. So level 1 low dose budesonide formoterol taken as needed. So what is AR only mean? What is AR only? So AR only mean what, doctors? What is that? Anti-inflammatory. Okay. What is that? Anti-inflammatory reliever. Okay, anti-inflammatory reliever. Mm-hmm. Yeah, it's fine, doctor. No need to remember. Just I have asked because they have mentioned. So level 2, low dose smart. Okay, maintenance and reliever therapy. Maintenance treatment with low dose ICS formoterol plus extra dose from the same inhaler. Take as needed for relief of symptoms. Okay, you have to maintain low dose ICS formoterol plus extra dose when symptoms are aggravating, like when there is a acute symptoms present, you have to take it as needed as reliever therapy. Hope you understand what I'm telling, right? Yeah. Here, we use low-dose budesonide formoterol as needed, but in level 2, we use it as a maintenance therapy, continuous therapy, and plus extra dose from same inhaler as need when there is some acute symptoms. You can see like patient having like acute wheeze, acute shortness of breath. Then you have to add these extra dose from the same inhaler, take as needed for relief symptoms. I'll show. Okay, here. Okay, here how MART works here. Maintenance dose as reliever dose. So maintenance dose mean everyday dose. Example 1 to 2 puff morning and evening. So reliever dose when symptoms occur. Like wheeze, breathlessness, chest tightness occur, you patient have to take some extra doses, right? Like that. So don't confuse. This is a very easier one, okay? Then third stage. So step 3. ICS formoterol maintenance and reliever therapy, but in here the medium dose. Why? The patient is having more symptoms and more exacerbation, right? The everything is increased here, right? Increased here. Because of that, we have to use the medium dose as the maintenance treatment. So medium dose maintenance treatment, ICS formoterol. So here higher number of inhalation using low dose inhalation, right? So we are using low dose inhaler, but we use higher number of inhalation to increase the dose, right? Yeah. Then plus extra dose from same inhaler take as needed for the relief symptoms, right? The same thing here. The only thing is maintenance dose is the medium dose, right? Medium dose. So level 4, consider add-on LAMA or trial of high-dose ICS LABA, right? So why? So here, the target intensive treatment, more intensive regime based on ICS, LABA, sometimes with add-on treatments such as LAMAs or monoclonal antibodies therapy. Mhm. So what are the alternative therapy here? Alternative therapy this side. So what are those? Alternative maintenance treatment with low dose of ICS plus SABA taken as needed for relief of symptoms. Level 2 maintenance treatment with low dose ICS LABA plus SABA taken as needed for relief. So level 3 maintenance treatment with medium dose of ICS LABA plus SABA taken as needed for relief of symptoms. All treatment level include ICS treatments solely with as needed. SABA is not recommended for adults or adults and with asthma. Even symptoms are infrequent. That is why this is the alternative pathway and this is the recommended pathway, right? Hope you understand everything. Because some doctors have personally texted me and asked me about the asthma management. Is something change or not like that? So this is the total asthma management. Right, doctors? Okay, so tell me LABA drugs. Okay, you are asking again. So what is the LABA drug? So I'm gonna ask the drug names. Okay, you have to tell me. So tell me Saba. Tell me Saba example. Saba drugs. Salbutamol, terbutaline, right? Yeah. Okay, then Sama. What are the Sama drugs? Short-acting muscarinic antagonist, ipratropium bromide. Then Laba, formoterol and salmeterol, right? Then Lama, tiotropium, right? It's very easy, doctors. Very easy, okay? Like who have a problem with that, please take a screenshot of this. Please take a screenshot of this. Saba, and just remember the drugs. Okay, please take a screenshot of this one and please keep these things in your mind. Okay. Yeah, that's also adult asthma. So I'm not going to discuss about pediatric asthma. It's a very easy topic, right? Pediatric asthma is a easy topic, and you have to follow these huge tree charts. So all done with asthma. So do you have any other questions? Anything? We have done maintenance therapy and acute treatment. So we will move to the next topic, right? Okay. So please do some at least 5 or 6 question like you can select the okay you can first of all you can go to the medicine search asthma and then you can I think 29 questions and you can select the asthma questions that only ask about treatment, then you can quickly do that. Okay, then you will understand everything. Otherwise, like actually I'm telling from my experience, the only knowing the theory is not enough for these asthma, because it's even though you are an expert in theory, in most of cases when they ask some questions you will be confused and get a wrong answer. So that's why I'm telling today please go and do the questions only they are asking about treatment. Other options known, then you can skip the asthma treatment, like in pediatric population. You have to do like for today this topic, you can do the adult one as well. Okay. Yeah. Okay, so yeah, we have done acute asthma. Yeah, yeah, doctor, we are using, wait. Mm, yeah, okay. I'll show it the again the picture here. As soon as practical and at least within the first hour, give oral corticosteroid therapy for all adults and children 6 years or older, children 1 to 5 years, unless the child has only a mild to moderate wheeze that responds to initial bronchodilator treatment. Why? This corticosteroid is a miraculous drug, right? Miraculous drug. I mentioned this part, right? Here, as soon as practical and at least within the first hour, give oral corticosteroid therapy. This is acute management of asthma, right? I explained this part as well, doctor. Okay, yeah. So we'll move to the next topic. So next, what we should discuss? Okay, we'll discuss about COPD, right? Yeah, COPD. Okay, pneumonia. Okay, we'll discuss pneumonia. Okay, I'm not gonna discuss like everything because I have explained it pneumonia in theory class. It took me like 2 hours, right? Like of doing questions and everything. But I'm telling you don't have to go through all the details in the video. Just focus the emergency questions. I think we have done so many emergency question in that part in our YouTube session. So at least do the emergency questions. Okay, let's see about pneumonia. Okay, so okay, now tell me 1 minute. Here they are just mainly asking from what? Mainly asking from what, doctors? Mainly asking from treatment, right? Treatment. And here you should know what are the hospital criteria, right? Hospital criteria. Here you should know about what you should know about what hospital admission criteria, right? And you should know about ICU admission criteria, right, doctor? I hope I'm telling. Yeah, this is, yeah, doctor. Here these two charts are very important because you should know these two charts, right? Two charts. Okay, so let's like quickly go through that. Then the most important, yes, another most important one is what? Most important one is the management. You should know the treatment, and what else? And you should know how you should diagnose is like that. Okay, so what is community acquired pneumonia? Pneumonia also we have different things, right? We have community acquired pneumonia, atypical pneumonia, hospital acquired pneumonia, and ventilator acquired pneumonia or ventilator associated pneumonia, something like that. Okay. Uh, so, but in most of the cases, they are asking from this community acquired pneumonia, right? Community acquired pneumonia. But just in case if they ask about other pneumonias, just remember the treatment options, right? Like how you should treat hospital acquired, like mild cases, moderate cases. So what are the antibiotics like that? You should remember. Okay. So let's discuss about community acquired pneumonia. So what is community acquired pneumonia, doctors? Mhm. So, community acquired pneumonia is the pneumonia that develop in the patient in the community or patient who have been hospital for less than 48 hours. Just 1 minute. Sorry for that. Yeah. So, however, pneumonia that develops in patient who has been discharged within the previous 7 days from hospital admission or longer than 48, we call it what? We call it hospital acquired pneumonia. You should know the two difference between this community acquired and if less than 48, if it is more than 48 hours or within previous 7 days from hospitalization, it is hospital acquired pneumonia, right? So, so let's see, like how you should manage these patients. So, first of all, tell me what are the clinical features? So, clinical features of pneumonia. Quickly tell me. We don't have much time. Okay, cough, fever, dyspnea, tachypnea, right? Saturation less than 95, pleuritic chest pain, rigors, heart rate more than 100. On chest examination, dullness to percussion. Why dullness, doctors? Why dullness? The reason for the dullness. Why we feel the dullness? Due to consolidation, right? Yes, due to consolidation. Good. Okay, dullness, then poor air entry, bronchial breath sound, crepitations or auscultation that do not clear with coffee, right? And here, in some patients with community-acquired pneumonia, especially older one, and non-respiratory symptoms also can be prominent. Diarrhea, headache, confusion, but these symptoms mostly associated with atypical pneumonia, right? Yeah, atypical pneumonia. Okay, so here, so adult with clinical features of community-acquired pneumonia. Okay, patient presenting with this cough, fever, then is tachypnea, tachycardia, right? Then the percussion. So patient is present into the hospital and what you should do. So first of all, you have to know, does the patient have any of following features that may indicate need for hospital admission? So what is tachypnea? Respiratory rate 22 breaths per minute or more. Tachycardia, heart rate more than 100 or more, sorry, more than 100. Hypotension, so systolic blood pressure less than 90. Acute onset confusion, oxygen saturation less than 92. Multilobular involvement of chest X-ray if only available. Blood lactate concentration more than 2 millimoles per liter if available. So tell me, what are those features, doctors? What are those features? Yeah, what are those features? Like you don't have to anyway like specifically remember these things. You know these features, right? So what are those? Yeah, I mean severe pneumonia, right? Yeah, severe pneumonia and like increase the lactate level mean and increase hypotension. That like it's a severe cases like that patient presenting with severe sepsis or patient can be severe shock, right? So these features like usually a hemodynamically unstable patient, right? Yeah, if you see this patient, you have to admission the patient to hospital. If these features present, yes. Okay, let's discuss it later. If it is not, then what you should do? Are there other reason to admit patient to hospital? If these features are not present, that means patient is hemodynamically stable, right? Then again, we have to consider still if there is any case that we can administer these patients to hospital. So, like social circumstances, in particular, availability of home support, age, comorbidities, ability to tolerate or absorb oral therapy, need for supportive oxygen therapy, functional status, like that. Okay. And also consider patients' preferences, prognosis, and goal of care. Okay. Then, if here 1 minute. If other reasons present, yes, then low severity community acquired pneumonia requiring hospital admission. If it is not present, here also low severity community acquired pneumonia, not requiring hospital admission, right? Why they have mentioned like this? I will explain when we discussing about the theory. When you discuss not theory, sorry, actually the treatment part, you will understand. Okay, yeah. If the patient is hemodynamically unstable, then again you have to consider something. Does patient have any of following feature that indicate benefits of intensive care unit? So we have to consider about patient need ICU support or not. So signs of severe acute respiratory insufficiency, respiratory rate 30 or more, saturation less than 90, multilobular or rapid progression of chest X-ray, infiltrate, signs of acute extrapulmonary organ dysfunction, hypotension, acute onset confusion, poor peripheral perfusion or mottled skin, acute oliguria, elevated serum creatinine or uremia, right, like that, and blood lactate concentration more than 2. Right? Yeah. If it is yes, then high severity community acquired pneumonia. If it is no, moderate severity. So that's how you have to categorize these patients and treat these patients as well, right? Hope you understand. Then yes, the same thing they have mentioned. And red flags for intensive support. So yeah, the same thing we just discussed from that chart. Okay. And what do you know about this pneumonia scoring systems? So, what are those pneumonia scoring systems? We have what we have this curve 65, right? Curve 65, CRB 65. Then we have smart COP as well, right? Yeah, COP as well. I'm not gonna discuss about those things, okay? Because here, however, these tools have limited sensitivity and specificity and aid clinical judgment rather than replace it. Pneumonia severity scoring tools are only relevant in population for which they were developed. Some studies in the other population reported poor result. If of not, CUB 65 or CRB 65 do not account for the comorbidities and hypoxemia in younger patient younger than 50 with hypoxemia, pneumonia, severity can be underestimated, right? So that's what these are not very sensitive, right? These tools. Okay, so yeah, etiology, we are not discussing about etiology now. So investigations. So what are the investigations, doctors? Here, according to low, moderate, high severity. So low severity, oxygen saturation on normal, consider chest X-ray, right? And not. So moderate severity one, oxygen saturation, chest X-ray, blood culture, consider NAT and sputum, gram stain and culture. So high severity oxygen saturation is a must thing you have to check. Chest X-ray, blood culture, NAT, sputum, gram stain, and culture arterial blood gas analysis. Because in high severity cases there can be severe case and acidosis and increase of the lactate and everything can be seen. What place doctor for diagnosis? Which criteria do we use? Here, there's no criteria, doctor. These are the investigations that we are using here. Okay, these are the investigations. Dr. Grace, like if you need like more details, please watch the YouTube video, right? Please watch the YouTube video because I have explained each test and everything very clearly. Today we are having a revision and we don't have time. Okay, yeah. No, it's fine because most doctors have exam on next week, so we have to do the quick revision, right? Yeah. Okay, then other high severity other tests we can consider pneumococcal urinary antigen assay, Legionella urinary antigen assay, storing serum for serology, right? But the main you have to remember about oxygen saturation, chest X-ray, right? And these knots and sputum, gram stain and cultures depend doctors, right? But most of the case, if there is a pneumonia present, we are doing the chest X-ray, right? Yeah. Okay. So here they have explained. Let's discuss about the treatment quickly. Okay. Okay, so let's discuss. Here, monotherapy for low severity community acquired pneumonia in adults. So, monotherapy targets Streptococcus pneumonia, the most common cause of bacterial community acquired pneumonia, is recommended for most adults with low severity community acquired pneumonia to minimize the adverse effect. Early clinical review of the patient is recommended because modification of therapy or reassessment of disease severity may be required. So, amoxicillin is the drug of choice for monotherapy because increase in rates of Streptococcus pneumonia resistant tetracycline and macrolides. For adults with low severity community acquired pneumonia, the treatment choice is what? Amoxicillin, right? Amoxicillin. What? Low severity, what we should use amoxicillin as a monotherapy if the patient is atypical one. So you all know what is the treatment for atypical pathogens, right? Atypical pathogens like mycoplasma pneumonia, chlamydia pneumonia, right? Legionella. So many atypical pneumonia cases, and if there's atypical pneumonia present, we can use doxycycline as the first line treatment and the second line as clarithromycin, right? So remember these names. Then, okay, for now you can forget about atypical part. Okay, for typical for just community acquired pneumonia, first line treatment is monotherapy. With monotherapy, we are using amoxicillin, right? As the if the patient presenting with hypersensitivity to penicillin, what you can use here? Here also you can use what? Doxycycline and clarithromycin. So you know doxy and clarithromycin for two cases, right? Two cases what? So if the patient presented with atypical pneumonia, the first line treatment is doxy and second line clarithromycin. If the patient presented with community acquired pneumonia, low severity, right? Low severity, but patient is having a penicillin allergy, then what you should give? Then you can consider about what? Then you can consider about doxycycline, if not clarithromycin, right? Okay. Okay, so then we have combination therapy for low severity community acquired pneumonia. So when we use low severity community acquired pneumonia, the combination therapy. So usually we are using monotherapy, but we have to use combination therapy in some cases. In where? Please remember, most of doctors have no idea about this combination therapy in low severity, this community acquired pneumonia. So we use combination therapy in low severity cases only patient presenting with other comorbidities like advanced heart, liver or kidney diseases or frailty, right? Sorry. And there is a risk of follow-up may not occur. Use initial combination therapy. If monotherapy is the recommended one, okay, remember, if they ask the initial treatment, this is monotherapy, right? With amoxicillin. But if the patient present with some heart disease or kidney diseases or like liver diseases, like chronic diseases, we have to think about adding something else because these patients are very high risk, right? High risk. So because of that, we have to add something else. So then we have combination therapy. So combination therapy, we have the same monotherapy plus either doxy or clarithromycin, right? This is the combination therapy. Okay, then for patients who have an immediate or delayed hypersensitive reaction to penicillin, replace penicillin in above regime with cefuroxime, right? Cefuroxime. If the patient is allergic to penicillin, you can replace it with cefuroxime, right? Cefuroxime. Please remember these things, okay? Yeah. Then, okay, here. because there can be due to some viral pathogens as well. Then it's a different thing, right? Doctor, influenza and the treatment, but we are here discuss mainly about the bacterial pathology. Okay. So duration. So what is the duration of low severity community acquired pneumonia treatment? Low severity community acquired pneumonia treatment duration. Yes, just what, 5 days, right? 5 days. And review on duration 5 days. Consider stopping antibiotic therapy on review at 3 days if the patient is clinically stable. In patients who are not clinically stable by 5 days, at higher risk of mortality and worse clinical outcomes, if pneumonia remains the likely diagnosis of the patient management community. And again, if the patient is not like resolving with these medications, you have to reassess the severity, right? Okay, so simply, what is the treatment option? Okay, here we have low severity. We have low severity. Low severity one also we have two things to remember, right? Remember what? Monotherapy and combined therapy. So when we use monotherapy as an initial therapy without other comorbidities, right? So the first line is amoxicillin, right? Amoxicillin. If the patient is having sensitivity to penicillin, then you can use doxy or clarithrolide. Okay, then next one, the combined therapy we are using patient with comorbidities with liver, kidney, heart, right? So we are using combination therapy. Here also, we add, sorry, we add another drug for this monotherapy. So what is the monotherapy? Okay, what happened? So we are adding amoxicillin with what? Doxy or clarithrol, right? Doxy or clarithrol. If this initial combination therapy is patient has penicillin allergy, then what we can do? Then what we can do if the patient is having penicillin allergy in this combination therapy? What is the drug of choice? Yeah, cefuroximine, right? Good, good, good. Don't confuse. I'm asking about that combined therapy, not monotherapy. Hope you understand. Make a short note. Then you will never forget it. Okay, yeah. So then we have moderate severity community acquired pneumonia. So moderate severity, how you should treat, doctors? Moderate severity. We have oral therapy for moderate severity community acquired pneumonia. So what is the treatment, doctor, here? What are the treatment we are using here? Yes, here we are using, but here also we use combination therapy, right? Combination therapy. Amoxi plus either doxy or acetro or clarithromycin. Here also we are using combination therapy. Combination therapy, right? Okay, then another thing. If the patient is having hypersensitivity to penicillin, amoxicillin can be replaced with cefuroxime. Okay, good. Then for adults with moderate severity cap who have a severe uh, immediate hypersensitivity for reaction to penicillin monotherapy, so you can use moxifloxacin. Moxifloxacin. Okay, then we have something else. Okay. 1 minute. Yeah. Here, for adults with moderate severity community acquired pneumonia, who cannot tolerate, who can tolerate absorb oral therapy have appropriate clinical review. Oral amoxicillin can be used as initial therapy instead of benzyl penicillin because it has good bioavailability. Mhm. Okay, so and one more thing you should know, we'll discuss that one as well. So intravenous therapy. So when we use this intravenous therapy, Intravenous therapy, doctors. When we use intravenous therapy. Mm-hmm. Give me example. When patient can't tolerate oral therapy. Mm-hmm. Yes. Patient is presenting with vomiting, right? Yeah, those are the example. Yeah. Here, adult with moderate severity, community acquired pneumonia who are not suitable for oral therapy, we use two drug regime. Benzyl penicillin 1.2 grams intravenously plus one of following doxy, acitro or claritro. If enteral therapy is not possible, intravenous azithromycin can be used. For adult with non-severe hypersensitivity to penicillin, we can use ceftriaxone, right here. We can use then, like the final option, we have moxifloxacin if the patient is having immediate severe reaction to this penicillin, right? Moxifloxacin. Okay, next one. Okay, and they have something else mentioned here. Empirical therapy for moderate severity community acquired pneumonia in tropical regions of Australia. Why? Why there's another? Why the treatment is changed in tropical area of Australia? Why? In tropical areas. Mm-hmm. Okay, here. In tropical regions of Australia, the gram-negative bacteria, Burkholderia pseudomonale, which cause melioidosis, and Acinetobacter baumannii can cause community-acquired pneumonia. Uh, so cases are also occasionally seen further south. Follow local protocol if available. In the absence of local protocol, the following regime may be appropriate. Here, manage patient. Yeah, if you are suspecting these, what is that? Yeah, Burkholderia pseudomonale, Acinetobacter baumannii. So we have to change the drug regime, right? So we have to replace the empirical treatment with ceftriaxone 2 grams intravenously daily. Right? If Bowman suspected, you can give gentamicin as well, right? Intravenously. If the patient who has severe immediate penicillin reaction, can give moxifloxacin. Mm-hmm. Atypical one we will do later, okay? Yeah, like that. So now tell me, uh, like no need to go through this one again, okay? Like if the patient is on intravenous therapy and patient is progressing, we have to change into the oral therapy, right? Oral therapy. So like what is the indications that we uh, oral switch to oral therapy, intravenous to oral therapy in these moderate cases? Here for adults with moderate severity community acquired pneumonia who started with intravenous therapy, switch to oral or enteral therapy once the patient has improved and clinically stable. Here, doctors, these are the guidance for intravenous to switch oral. Yeah, symptoms improved one. If it is appropriate to switch patient's therapy from intravenous to oral when the following apply, patient has a functional gastrointestinal symptom. There is a clinical improvement. Fever is resolved or improving. There is no unexplained 1 minute. Sorry. There's no unexplained hemodynamic instability or oral intake is tolerated and there are no concern about malabsorption. A suitable regime of oral antimicrobial is available with adequate penetration to the site of infection that either has the same or similar spectrum of intravenous antimicrobial or is an oral formulation in the same drug. Okay, just keep in the mind, okay, these things. Yeah. Then we will discuss about, high severity. Just 1 minute. Oh, sorry. Okay, so let's consider about high severity. Okay, here, if the patient is having high severity community acquired pneumonia, these patients are highest risk of mortality, right? Highest risk of mortality. So here, so empirical treatment for high severity community acquired pneumonia in adults for management consideration include adjustment empirical treatment. Example like in tropical cases, it's different, right? For adults with high severity community acquired pneumonia as two drug regime use ceftriaxone plus azithromycin. Ceftriaxone plus azithromycin. So tell me another case that we are using this combination ceftriaxone plus azithromycin. Tell me, doctors, where we are using this combination. Yes, gonorrhea, right? AC. That day also I told you. Remember, here also in high severity community acquired pneumonia also we use this AC combination, right? AC combination, right? If the patient is having severe immediate reaction to penicillin in whom ceftriaxone is not used, and patient who have had severe delay in penicillin as monotherapy, you can use moxifloxacin, right? Then, so what is the empirical therapy for high severity community acquired pneumonia in tropical region? Here, this is the tropical region. So in tropical region, this Burkholderia pseudomonale and this Acinetobacter bumania important cases. In that case, we are using but meropenem with azithromycin, meropenem, right? Remember, yeah, doctors. Yes. Let's see. Okay. Yeah, and who is a Pseudomonas aeruginosa? Who is a Pseudomonas aeruginosa? Which type of pathogen is gram negative or positive? Tell me, doctor, is gram positive or negative? Negative. What doctor about? I missed the treatment. Okay, I'll show it again. Here. So tropical area of high severity, we have to give meropenem plus azithromycin, right? Tropical regions. Okay. So here, yeah, empirical therapy here for high severity cap in adults suspecting Pseudomonas aeruginosa, right? Okay, in this case, this is a gram negative bacilli predominant on gram stain or identified culture sputum. So it's a gram negative bacilli, right? Gram negative bacilli. So in this case, we can add this cefepime or piptas plus azithromycin plus topramycin or gentamicin. Hope you understand it. Is for who? Here, empirical therapy suspected pseudomonas in high severity, community acquired pneumonia in adults. High severity, pseudomonas suspected. So, this is the treatment. Cefepime or piperacillin tazobactam plus with either of above regime with azithromycin plus. So, how many drugs here we are using? Which how many drugs? In pseudomonas high risk cases, three drugs, right? So give me a combination. Cefepime, azithromycin plus Genta, Genta we can use. Or we can use Piptas plus azithromycin plus gentamicin or topramycin. Let's depend, right? Here you have to remember if the patient is presented with high risk and they have given something related to Pseudomonas aeruginosa and you all know it's a gram negative one, in that case you can use this three drug regime, right? Three drug regime, right? So please remember. I don't think they will ask from that. Yes, yeah, Gentacitro, Piptas. Yeah, that's a good one, Dr. Bag. Yeah, you can remember like that. These are not very, very important. And one more thing about this vancomycin. What do you know about vancomycin? When we are adding vancomycin, doctors, if we are suspecting what? Yeah, if you're suspecting MRSA, you have to add vancomycin as that's a typical one we all know, right? Yeah, that's all for community acquired pneumonia, doctor. Like this is a huge topic, but that is the that's the very simplest summary that I can give, okay? Because it's a huge topic. So yeah, we will take a small break, right? We'll take a small break and we'll continue. Most of the cases they are given, doctor. Do you remember that diabetic questions? They have given like methicillin resistant, and I can't properly remember. Most of the cases they are given like, especially in the hospital situation, and like it's depend on the questions, doctor. We can't just tell like they are giving exactly like this. Like when you're doing the question, you will understand it. Okay? Yeah. So we'll meet after 10 minutes. Okay. Hello, doctor. So we will continue. Okay. Next, we will discuss about COPD, right? Okay. So, what do you know about COPD? Tell me, doctor. COPD also have two types of management, right? So, what are those? There are two types of management. Tell me. Here also we have a stable COPD management. That means the maintenance treatment, and we have COPD exacerbation management, right? Is everyone here? Mm-hmm. Okay. Yeah. Okay. So, what is COPD, doctors? What is a COPD? It's a chronic obstructive pulmonary disease, right? Okay. This is a reversible disease or irreversible disease. Can we reverse the effect of this obstruction? And yeah, it's irreversible disease, right? But this is long term destruction of the alveolar structure, right? Emphysema, right, doctors? And persistent airflow limitation resulting from the combination of small airway disease and alveolar destruction. We call it emphysema. It caused by abnormal inflammatory response in the lung to noxious particles of gases. Tobacco smoke. COPD is a progressive disease. However, smoking cessation can slow progression, and treatment can improve the patient's quality of life. There's a no cure, right? There's a no cure. The only thing we can do is manage this patient, and this is the maintenance treatment we are just discussing. Okay. And tell me how we should diagnose this COPD. How we should diagnose COPD, doctors? How we should diagnose spirometry. Okay, what we can see during the spirometry. What you can see during the spirometry. Mm-hmm. Okay, obstructive pattern, right? So what does mean obstructive pattern? Tell me, doctors. Tell me. So what are the other disease uh, who was having obstructive pattern? Mm-hmm. Asthma. So what are those? ABC. So what are the other two diseases? ABC? Do you remember? Do you remember or not? I have explained. Yes. A mean, but A mean asthma, right? B mean bronchiectasis, right? C means COPD, right? Yeah, so please remember, okay, not bronchitis, bronchiectasis, okay? Okay, so in here, 0.7 mean what? FPV1 divided by FPC, right? FPC. So it's usually, but we can see less than 0.7, right? 0.7. So, yeah, good. You know about it. Then what else? What do you know about reversibility test? So what is reversibility test? How we should do it? Yeah, how we are doing that reversibility test? Mm-hmm. Usually we are doing reversibility tests to get an idea about this COPD is irreversible or reversible, right? Like if it is reversible, we can take it as asthma, right? To differentiate. So first we are do the spirometry, right? Then we are giving bronchodilators, usually salbutamol, right? Then we are repeats this spirometry after 10 to 15 minutes, right, doctors? 10 to 15 minutes. And if it is reversible, what should be present? If this is reversible, this FEV1 should be increased more than 12%, right? More than 12%. But in this case, but in COPD, it is not increasing more than 12%. That means not reverse, it's not reversible, right? That means irreversible, right? So that's all. Yeah. Then, okay, yes, we just discussed about it. Mhm. Then you should know about the severity of COPD. So, severity of COPD, we have mild, moderate, severe. So mild one is few symptoms, breathlessness on moderate exertion, daily activities minimally limited or unaffected, cough and sputum production, right? These are the mild case. Then typical lung function FEV1 60 to 80% predicted, and moderate one breathlessness walking on the level ground, daily activity increasingly limited, Recurrent chest infections, exacerbation requiring oral corticosteroid or antibiotics, right? FVV1 40 to 59. So severe cases, breathlessness on minimal exertion, daily activities severely limited, exacerbation is increasing frequently and severely, right? Yeah. So FVV1 here less than 40% predicted. So please remember you should know about this COPD severity as well. Just remember about this lung function as well, right? Because in like usually in worldwide we are using what doctors. I have explained when I was doing the COPD. We are using what criteria in worldwide? We are using gold criteria, right? But in AMC, they have not mentioned anything like that. But here they have given about mild, moderate, severe, this FVV1, yeah, FVV1 criteria. So because of that, please remember this one, like mild case present with 60 to 80%, moderate case 40 to 59, right? 40 to 59, then severe case less than 40, right? Please remember. Okay. Then let's discuss about the treatment. Yeah, this is the treatment stepwise. So, for mild, moderate, or severe, all cases, first of all, we have to do the general management. So, what is the main thing? You have to you have to stop the smoking, right? Patients should stop the smoking, right, doctors? Here, reduce risk factors, avoid exposure to the risk factors, right? Tobacco, smoke, air pollution, right? And yeah. Yeah, in the emergency they have used gold. Yeah, I remember. We have done the question, but in here they have not mentioned. If you want like get an idea, because I have explained this gold one in our theory session as well. Please just go and check it. Okay, I can just read it as well. Okay, remember. This is from the university, right, Dr. Bhagya? Because otherwise I can just search and find the newest guideline. Okay, yeah. So all doctors follow Dr. Bhagya's mentioned this goal criteria. So mild mean more than 80, moderate mean 50 to 79, severe 30 to 49, and very severe less than 30. Okay, just keep those things in your mind as well. Okay, yeah, good. Because we never know, right? But in TG they have not mentioned about gold criteria, but we all know like world accepted guideline for the guideline for COPD is gold criteria, right? Gold criteria. So just keep those things in your mind. They are very easy. So first thing, reduce the risk factors that optimize function, encourage regular exercise and physical activities, review nutrition, provide education about COPD, develop GP management plan and write COPD action plan and undertake regular review. Then optimize treatment comorbidities like cardiovascular disease, anxiety, depression, right? These are the general management, right? But the most important part is stepwise drug management. Please remember this is the most important one. Most important one. I am telling again the most important one. So for all mild, moderate, or severe, each cases we are starting with what? We are starting with what, doctors? Type in the chat. We are starting with what? We are starting with Sabha right here. Start with as needed short acting bronchodilator therapy. But they are as needed, right? As needed. Remember? Then start regular long acting bronchodilator monotherapy with a LAMA or LABA. So, okay, first thing first, they have mentioned as needed SABA, right? As needed SABA. Then number two, what? Lama or Laba monotherapy. Lama or Laba monotherapy, right? Lama or Laba monotherapy. Then, if this is not working, start regular long-acting bronchodilator dual therapy with a LAMA and a LABA if not controlled with monotherapy. So, as needed Sabha and uh, like here this is for as needed, right? As needed, like but the main regular treatment, so maintenance treatment, we are starting with this monotherapy, right? Monotherapy with lama or laba. So, give me example for lama and laba again. Lama and laba. Tell me lama and laba again. Lama what? Mm-hmm. Lama. Theotropium, right? Theotropium, laba, salmeterol, and formoterol, right? Yes. So remember. So initially, either lama or laba. So monotherapy. If it is not working, we are going with dual therapy. So dual therapy, what include? Dual therapy has what? Dual therapy has laba plus lama. Here, laba plus lama, right? Yeah, laba plus lama. And so, laba drugs, what? Formoterol, right? Then lama, other drugs. What are the other drugs we have? What are the other drugs we have, doctors? Other than theotropium, we have which drug? Because in COPD, we have other drugs as well. So tell me, give me example because I have explained these things. Okay, you can't tell me. Okay, other than ipratropium. Mm-hmm. Yes, we have what? Aclidium, right? Aclidium, not acidium, sorry. Aclidium. Here you can remember this dual or combination therapy as all plus om, right? Mean formoterol plus acidium as right? Right, doctors, you can remember combination drug therapy like that. Then, if this dual therapy or combination therapy is not working, then what we can do? We can try what, doctors? We can try which therapy? Okay, monotherapy has given it's not no effect. Then we have tried dual therapy. Then dual therapy also not effective. Then what we can try? We can try triple therapy, right? Triple therapy. This is a very easy one. Okay, triple therapy. So, what are the options we have in triple therapy? Triple therapy. We have triple therapy, LAMA, LABA, and ICS, inhaled corticosteroid triple therapy. Why? And if both the following apply, following apply, because this part has asked in emergency as well, so you should know these two things. A patient has had a severe exacerbation requiring hospitalization or at least two moderate exacerbation in the past 12 months and the patient has significant symptoms despite dual therapy with LAMA or LABA. Then only we can add these ICS, right? ICS and continue as triple therapy, right? Okay, so now tell me in here, the drug therapy is the most important part, right? Because you all know about general therapy. So, what is the first thing we need? Okay, so what is the first therapy? Tell me, what is the first therapy? We all know as needed Sabha we can use, right? As needed Sabha we can use anytime. Other than that, what is the first therapy? Yes, we have the monotherapy, right? Monotherapy. So monotherapy it can be either lama or laba, right? Lama or laba. Then if it is not working, we have what? We have dual therapy. Dual therapy means there is a combination. There should be a two drug, right? So what are those? Here lama and laba. Lama and laba, right? Lama and laba. Then if this dual therapy also not working and both of following present in this patient, Like patient has significant symptoms despite with dual therapy, and both should be there to add another drug. The patient has had severe exacerbation required hospitalization, or at least two moderate exacerbation in the past 12 months. If these two criteria is fulfilled, then we can give the triple therapy. That means we can add inhale corticosteroid to this dual therapy, and we can call it a triple therapy, right? This is the management plan. This is very easy, doctors, very easy one. So you just have to get the concepts only, right? Concepts only. Yeah. Okay. Then assess the optimized inhaler device technique at each visit. Like that. Okay. So mhm. Okay. Here. Remember about this aclidinum, okay? Aclidinum man. This glyco. Usually, I have seen this aclidinum. They have given, okay. So this umeclidinium, theotropium, glycopyrronium. Okay. So remember these, and all, right? And all together in dual tray. They are not like given, they are not like very different, doctors. Some cases they are given about uh these criteria, like they have in the explanation they have mentioned, as I remember, they have mentioned about according to this criteria, this is under this is under mild, this is under mild COPD, moderate COPD, like that. But you all know, like all the cases, even though it's mild, moderate, severe, we have to follow this stepwise approach, right? Even though if it is mild, moderate, or severe, we have to follow this approach. Then there's no problem if they ask to like diagnose is severe moderate, then that is the problem. Yeah, eosinophilic thing. Yeah, I remember, doctors. So yeah, just 1 minute. I'll show, because I hope everyone is having my short note for this COPD. Okay, COPD, and I have added a specific part. Okay, not yet. Just 1 minute. I will show. It's in the group, doctors. I think you all can just download it. My COPD note. Yes. Got 95 files in our. Okay, let's. Not in this. The most recent one. No, not these two. I'll share it, doctors. Now I'm going to share a PDF. This is my short note. I have shared it in the main group, but not in this. There are so many notes, doctor. That's the problem. Please download this one, doctors. I have attached everything here. The thing you need to know. Okay, here. Yeah, I hope. Oh, yeah, you have shared it. Okay, thank you so much, doctor. And in my note also, you can see. Don't mind my writings, okay? This is the very simplest thing that you can follow. Okay, here. Yeah. Okay, this is the stepwise management. There's a eMedSIP one. Okay, here. Yeah. Okay, this is for the eosinophilic one. Okay, yeah. There was a question because I don't have that question here, doctors. If Dr. Bhagya can find it, please share it the group. The relatively normal inflammatory markers like CPR 12 milligrams per liter suggest the acute exacerbation has resolved, but the persistent symptoms, elevated eosinophils, and asthma history support the need for triple therapy to prevent the future exacerbation and improve the symptoms control. Okay, there's a point that you should remember. Patient with COPD who have blood eosinophils more than 300 cells and remain symptomatic after hospitalization benefits from the triple therapy. Benefits from the triple therapy. So please remember, blood eosinophils count help to predict the response to inhaled corticosteroid in COPD patient with exacerbation history. So triple therapy reduces the exacerbation risk more than the dual bronchodilator therapy. So you know another point, right? You know another point. So usual indicator for this one here, more than or equal to more than one severe exacerbation require hospitalization, or equal or more than two moderate exacerbation in last 2 months, and then persistent symptoms despite LABA and LAMA, the dual treatment. So we can think about triple therapy. And other than these two, there's another indications. The emergency point is this, okay? If the patient is presenting after the hospitalization and still symptoms persistent, eosinophil count is more than 300, you have to think about giving triple therapy, right? So please keep these things also in your mind, okay? Yeah. Okay, so please, yeah. Okay, yeah. Don't mind this part, okay? I'll explain it. Yeah. There's some mistakes I have done in that, I think. Okay, now next we will discuss about the exacerbation, right? COPD exacerbation. So let's go through it. Okay, so what do you know about COPD exacerbation, doctors? COPD exacerbation, what do you know about exacerbations? So, what is exacerbation? Exacerbation of a chronic obstructive pulmonary disease is a characteristic by acute worsening of symptoms beyond normal day-to-day variations, right? Just acute symptoms, right? Present. Increased dyspnea, reduced exercise tolerance, tachypnea, increased cough frequency, increased sputum volume or purulence, fever, right? Right heart failure may manifest in as ankle edema, right? Okay. So how we should treat COPD exacerbation? Very easy. Doctors, tell me how we should treat these COPD exacerbations. Tell me, doctors. Stepwise, tell me. There are only 3 points you should remember. Hmm. Okay, let's check. So here, treatment of COPD. No, they have mentioned there's no flow chart here. Treatment of COPD. So remember, you should remember these things. An exacerbation of chronic obstructive pulmonary disease is managed with bronchodilator therapy at the onset symptoms. Bronchodilator therapy can be started by the patient at home in according to their COPD action plan, right? Here, salbutamol, terbutaline, and ipratropium appears to be. Doctors, just give me 1 minute. I'm getting a call. Just 1 minute. Hello, doctor. Sorry for that. Yeah, I got a call. So, uh, ipratropium steroid. Okay, so let's discuss here. Okay, so we had to start with what bronchodilators, right? Inhaled bronchodilators. So salbutamol, terbutaline, and ipratropium appears to work equally well relieve the symptoms of COPD exacerbation. However, ipratropium has a slower onset of effect than salbutamol and is contraindicated in patients taking a long-acting muscarinic antagonist, right? Delivery via pressurized meters dose inhaled or PMDI with spacer appears to be effective as delivery via nebulizer for patient with forced expiratory volume in 1 second more than 30% of predicted value, right? So the initial treatment of exacerbation is salbutamol or terbutaline or ipratropium. So please remember, if a nebulizer is required, it should be driven by compressed air rather than oxygen to avoid excessive and potentially fatal hyperoxygenation. If appropriate, salbutamol inhalation via nebulizer as required or ipratropium via nebulizer as required. Okay. Here, if one drug does, this is the another important part. Most doctors have forget this part. If one drug does not control symptoms adequately, or if symptoms are severe, combining salbutamol and ipratropium at the above dose may provide added benefit without compounding adverse effect. Right? Right, doctors? Where's that? It. So you can simply. Yes, my chart. Okay. Dr. Grace has shared a question as well. We'll do it later, okay? Just 1 minute. I wanted to share my note. Okay, here. Simply, you can remember Saba or Sama as required. Salbutamol, terbutaline, ipratropium. If it is very severe, can combine salbutamol, ipratropium acid. Right? Don't mind my writing, okay? It is a very quick note that I have made. Yeah, but I think this will be helpful for you as well. That's why I have shared, okay? Because most of doctors have missed this part. Okay, like bronchodilators therapy may be sufficient to relieve mild COPD exacerbation. Okay, then what do you know about systemic corticosteroid? A 5-day course of systemic corticosteroid is recommended for exacerbation that don't respond sufficient to the inhaled bronchodilators. So, systemic corticosteroids shorten the duration of hospital admission and hasn't returned to previous lung function and symptom control. Patient with written COPD action plan may have already started oral corticosteroid when they present with the medical attention. Okay, so if the patient can take oral medications, you can give prednisolone 30 to 50 milligrams only once daily for 5 days. Remember the 5 days course, okay? Oral medications can't tolerate it, then you can give hydrocortisone IV 50 milligrams 6 hourly until oral intake is tolerated. Yes, switch the patient to oral therapy as soon as tolerated and continue for a total of 5 days therapy. Total 5 days, okay? Even though if it is IV or oral, total should be 5 days, right? So remember. Then what do you know about antibiotic? Antibiotic doctors, let's see. Yeah, antibiotic. Okay. When we should consider antibiotic in COPD. This is the very high yield another point. Okay. Patient with because for the exacerbation we have three things mainly, right? inhaled bronchodilators, then we have systemic corticosteroid, and we have antibiotics as well. But before giving antibiotics, there's a criteria that should fulfill, right? Before starting antibiotic. Other than we have oxygen therapy as well. Okay. Okay. Here, patient with COPD exacerbation. Does the patient require ICU or mechanical ventilation? If it is not, if it is yes, anyway, you have to give antibiotic. Okay, you have to give antibiotic anyway. If it is no, then another criteria. Does the patient have increased sputum purulence? If it is no, do not use antibiotic therapy. If it is yes, then does the patient have increased sputum volume and or increased dyspnea? If it is yes, then consider starting antibiotic therapy. So what are the criteria? Okay, what is the number one? Tell me, because you have to know the stepwise mean how. Here number one, if the patient need ICU, you have to give antibiotic. Then what else? Then you have to consider patient's sputum purulence increase or not. If it is increase, then you have to think about what? Then you have to think about sputum volume, right? Sputum volume is increased or not, right? And patient is dyspneic or not, right? Right. So please remember these points, right? Mm-hmm. Yes, good. Please remember these are very high yield because you need to know these stepwise points, okay? I think I have written down something else here. That's why, yeah, that's why please follow this chart, okay? Don't read this one. Don't read this part. Just read this one, okay? Yeah. Okay. So, yeah. Then tell me, what is the antibiotic of choice? So, what is the antibiotic of choice? So, what is the antibiotic of choice, doctors? What we can give? We have amoxicillin, right? We have amoxicillin. Good. We have amoxicillin and doxy, right? Yeah. Okay. So this is the initial antibiotic therapy, right? Then if the initial antibiotic management exacerbation that are not improving, lack of response to the initial antibiotic therapy rarely requires switching broad spectrum therapy for patients with mild COPD. Symptoms of exacerbation can last 7 to 10 days. In patients with moderate to severe or symptomatic symptoms can persist for weeks. Okay, then when we use sputum call for the patient with severe COPD who have a COPD exacerbation that does not respond to the initial therapy, then you can think about amoxiclav, right? Then for patient with COPD exacerbation that does not respond to the initial antibiotic therapy after 48 to 72 hours, if bacterial infection remain likely to cause from this Pseudomonas aeruginosa, then ciprofloxacin, right? What? Which note, doctors? Which note? COPD. I think it's in the general group, doctor. And okay, don't mind. Please text me. Okay. 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 I'll share it. It's in the March group, and I will share in the main group. Yes, sir. Yeah, doctor. Then how long you should take the antibiotic treatment, doctors? How long? It's also for 5 days, right? Here, 5 days. Yeah, that's all for the COPD exacerbation as well. So, okay. So, yeah, 1 minute. Okay, we'll do this question. Is this the same question? Mm, okay, we'll do this a question. My God, it's very hard to manage this part. Yeah. Okay, so let's discuss. Okay, so this is the question, right? Okay, 68-year-old man, sorry, old man present to the GP clinic for follow-up. 1 week after discharge from hospital, he was admitted with the acute exacerbation of chronic obstructive pulmonary disease, requiring 5 days of inpatient treatment. He has a 45-year smoke history and quite 2 weeks ago, and he has a medical history of asthma, diagnosed in childhood COPD, and he does not take any regular medications. Sorry. Okay, this is the question, right? Yeah. Then on examination, he appears well but remains breathlessness on minimal exertion. Pulse 88, BP 135 by 80, respiratory rate 20, SpO2 94, then temperature 36.5. Chest examination revealed reduced air entry bilaterally with scattered expiratory V's. Investigation revealed hemoglobin 145, WBC 8.2, eosinophils 0.45, C-reactive protein 12. So spirometry FVV1 40, FVC 70, the ratio 0.43. Okay, so uh, they are asking which one of the following is most appropriate initial medication. So we have just discussed because of the eosinophilic level, right? So we have to give what? We have to give triple therapy, right, doctor? Thank you so much, doctor. Yeah, this is the question that I have mentioned. Yeah, doctor, please do this emergency question. Then only you will understand the concepts. Otherwise, like anyone can understand the theory behind it, right? Theory behind it. The only problem here is what? Only problem here is like you don't know how questions are coming, right? You have to think and you need to correct these key points, right, doctors? Okay, so let's discuss about these oxygen therapy as well. It's not very necessary. That's fine. Okay. Okay, we'll discuss. Yeah. So oxygen therapy, if a patient experiencing COPD exacerbation is hypoxemic, oxygen saturation measured by pulse oximetry less than 88. So tell me what is the normal level of oxygen saturation in COPD patients? Tell me, doctors. Yes. What about other doctors? Quickly tell me. You should know, right? The normal level. Tell me, doctors. Okay. Good. Mm-hmm. Between 88 and 92. Please remember, okay, it's different from the other people. COPD people has less saturation, right? Okay, here if there's less than 88, then only you have to think about oxygenation therapy, right? Administer oxygen, maintain SpO2 at 88 to 92. Patients with COPD are high risk of hypercapnic respiratory failure during exacerbation, and excessive supplemental oxygen is associated with increased mortality for yeah, information. Mm, 1 minute. Yeah. Okay, from here we'll discuss. So, what is the acute management of oxygen therapy? Monitor acute oxygen therapy with continuous pulse oximetry, document delivery system, and target oxygen saturation level may be different from children. Oh, yeah, we know. Okay, so what they have mentioned analysis, pulse oximetry. They have not mentioned anything properly. Yeah, they have not mentioned here like okay here. So here, what are the oxygen delivery systems that we are using in here? Standard nasal cannula, Venturi mask, simple face mask, and 100% non-rebreathable mask, and high flow nasal cannula. So high flow nasal cannula oxygen therapy provide the heated and humidified oxygen. They have not like specifically mentioned. Okay, but in I have this is I made from the EMC. So usually we can start from nasal prong. It's not working. We can use Venturi mask because in Venturi there's a low flow oxygenation. If the patient is deteriorating now, CO2 is the saturation is increasing, then you can use CPAP or BiPAP, right? BiPAP the recommended one. Okay, yeah, here. I know this is something else. I have got this from one question, but I can't remember. Okay, yeah, so just keep this thing in your mind because there's no proper one in here. Yes, BiPAP doctor recommended for BiPAP AMC. Okay, that's all for COPD. Yeah, next we will do about multiple sclerosis, right? Yeah. So, what is multiple sclerosis, doctors? Hope you understand everything. And please do this COP, at least 10 questions. Do the 10 questions because very high yield COPD asthma means very high yield, right? So, what is multiple sclerosis, doctors? Multiple sclerosis. I have explained multiple times, even in my recall class. I have explained each month, right? Multiple sclerosis that much important. Each month they are asking a question from multiple sclerosis. So, what is multiple sclerosis? What is happening here? It's a multifocal central nervous system disorder characteristic by inflammatory demyelination lesion affecting white and gray matter, right? Yeah, white and gray matter. Mhm. There's a demyelination, right, doctors? Yes. So now tell me what is the clinical presentation? What I'm just discussing only most important parts only, okay? So now tell me what is the clinical presentation? Okay, I'm asking the sites and you tell me the symptoms or sign, okay? When optic nerve, when it affect optic nerve, what we can see? When it affect optic nerve, what we can see, doctors? Yes, optic neuritis. So optic neuritis is unilateral or bilateral? It's a unilateral, right? So, in optic neuritic patient, what is the symptom that you can see? What is the symptoms that you can see? Okay, pain on eye movement, then blurred vision as well, right? So remember, pain on eye movement, they are not directly given. Patient presenting with optic neuritis. So you should know how it present, right? Pain, especially they are giving pain on eye movement, right? Blurred vision, right? Yeah, just 1 minute. 1 minute. Is it recording? Yeah, still recording, right? Yeah. Okay, I was just suddenly got a panic attack that I forget the recording button. Okay, it's recording, no problem. Yeah, every day I'm getting that panic attack. Okay, then when we discuss about cerebellum, if it affect the cerebellum, then what we can see? If it affects cerebellum, what we can see? Okay, limb or gait ataxia, right? Then what else? You can see nystagmus as well, right? Nystagmus as well, right? Yes, nystagmus as well. Horizontal or yeah, just remember horizontal nystagmus. Okay. Then then it affect a spinal cord. What you can see? You can see upper and lower limb weakness, right? Doctors, upper and lower limb weakness, right? Yes. Then what else? Mm-hmm. Okay. So what is hermit sign? What is hermit sign? So what is hermit sign? What is hermit sign, doctors? What is hermit sign? Mhm. Yes. When patient is bent in the neck, there is a shock-like feeling, right? Shock-like feeling. Yeah, in your spinal cord, right? Yeah. Then what is Uthoff phenomena? Uthoff phenomena? Uthoff, Uthoff phenomena. when when the patient's body is getting overheated, right? That means having a hot water bath, these symptoms can be worse, right? Yeah, symptoms are triggered, right, because of this increase in the temperature, right, doctors? Yeah. Then other than that, tells when if it affect the bowels and bladder, what we can see. Bladder, bowels, we can see urinary. Mhm. You can see urinary frequency, urge incontinence, right? Yes, and constipations also can be seen. No, doctor, you have to know about this, okay? Because this is a very high yield topic, and in each month we have discussed 2025 March, and we have discussed 2026 February, 2025 November, October, September. We have discussed all of them, and in each month there's a question from these multiple sclerosis. There's a question from these multiple sclerosis, so you should know the key points, right? Sometimes they ask to diagnose it. That's why these clinical features are very important, and in some cases they are asking us to diagnose it, right? Then you should know about the what is main diagnosis, the diagnosis method, right? In then they can ask from the treatment as well, right? Yes, treatment as well. Okay. Okay, now we have discussed about what the clinical features. Now tell me, what is the gold standard or initial or whatever main investigation for these multiple sclerosis, MRI. Please remember MRI. Even if they ask what is initial, even if they ask what is gold standard, it's always MRI. Yeah, it's a gadolinium contrast MRI, because this exactly mentioned in e-medicine, right? Please remember, okay? Please remember. And what we can see in this MRI, in my doctors who are in recall class, you should quickly answer. Okay, we have discussed, I think, 5 to 7 times, right? Where's Dr. Ritik? Okay, he's here. Dr. Arunima also here. Okay. Dr. Bhagya, yes. Dr. Vajra, yeah. Should remember, okay? In your mind, there should be a picture as well, right? About these dozen fingers. Yeah, yeah, doctor. MRI is the because without MRI we can't diagnose this, right? We can't diagnose. I will show, okay? And I'm gonna show this dozen fingers. This dozen fingers. Just 1 minute, okay? I'll show. Yeah. Can you see? These are like fingers, right here. Here, dozen fingers, like we are just like pinch it like that here from our fingers, right? No, doctor, I have separate recall classes, not like this. Yeah. So here, dozen fingers, right? Please remember these things, okay? Dozen fingers. And I'll show about the therapeutic guideline as that. Yes, here. This is a very high yield one. because sometimes you can think about like other investigation, they have given other investigations, but the MRI is the best and everything. Okay, 1 minute, I'll show it from here. Okay. No, before that. Mhm. Here, an MRI of CNS is a key diagnostic procedure for multiple sclerosis. It is usually arranged by the neurologist after referral, but increasing by being performed primary care. Okay, so what are the things we can see in here? Here, inflammatory lesion dissemination in space on the CNS, at least three of pericallosal or periventricular lesions, cortical, juxtacortical lesions, sorry, infra-attentorial lesion, spinal cord lesion. Like they are not asking from that, but you should know about this. MRI is the gold standard, right? Yeah. And with this initial clinical presentation, then we can do the MRI and confirm it, right? And we have other tests as well. So what are those other tests, doctors? What, if it is possible, could you please add most important question? Yeah, sure, doctor. Let's see. Okay, so other test, we have cerebrospinal fluid analysis, right? So in cerebrospinal fluid analysis, what you can see, doctors? Oligoclonal bland and oligoclonal band, right? Bands you can see here, oligoclonal immunoglobulin bands you can see in here. The presence of oligoclonal IgG band is not diagnostic of MS. Please remember they are not diagnostic and must be interpreted in the context of other clinical laboratory and imaging findings. Okay. So then we have evoked potential measurement. So what is this evoked potential measurement, doctors? Here, this evoked potential measurement, this shows the electrophysiological evidence of demyelinating lesion in the spinal cord, optic nerve or brain stem, and auditory evoke response, right? Evoke potential measurement. But MS can be diagnosed following a single typical event such as unilateral optic neuritis, provided the patient has MRI lesion fulfilling the criteria for dissemination space in the time, or MRI lesion fulfilling the dissemination space and CSF oligoclonal band, which demonstrate dissemination in time, right? So, but MRI should be in the scenario to fully diagnose it, right? Okay, so next one, you should know about the treatment. So now tell me, what is the mainstay of treatment, doctors? Because that is the another important one. Mm-hmm. Okay. Okay, Doctor Rehan, when we should use, when you should use methylprednisolone, in which case in multiple sclerosis? What do you think, doctors? Mm-hmm. Acute case, right? Yeah, in acute cases, right? If there's a flares up, then we have to use we have to use these IV methylprednisolone. It's depending on the situation, right? So here, the key aspect of multiple sclerosis management are disease modifying therapy to reduce the relapse rate and disabling progression, right? So this is what demyelination, and in this case, the mainstay of treatment is to prevent further event, right? Because so for that we have to give disease modifying therapy, or we call it DMT, to reduce relapse. This is the long-term treatment, right? This is the long-term treatment. Is a long-term treatment, right? Then corticosteroid for moderate to severe relapses, treatment of symptoms associated. Like then we have treatment according to the symptoms as well. But mainly you have to prescribe this patient for the long-term management. You have to give disease modifying therapy. So let's see what are those disease modifying therapy, right? So here, okay, disease modifying therapy. So here principle of use of disease modifying therapy in multiple sclerosis. Before starting treatment of MS, multiple sclerosis with DMT, yeah, what you should refer. Okay, okay, no need to read everything. Just simply remember these things. Okay. Yes, that. Yeah, we have discussed. Okay, here. Mm. And here, this is modifying therapy. This is modifying therapy used to reduce the relapses and rates of disability progression patient with multiple sclerosis. Okay, here DMT most indicated for relapse in MS, but can be used for some cases in primary and secondary progressive MS. The main aim is achieve no evidence of disease activity. There are multiple levels of this NEDA, that means no evidence of disease activity, but a common initial target. Yeah, just remember to prevent the relapses, okay? Otherwise, I don't want to fill your brains with unnecessary things, right? And you should know we have different types of disease modifying therapy, right? Disease modifying therapy also two things. In here, you should what 1 minute, doctor, we will discuss, okay? Here also we have disease modifying therapy and high effective therapies, and we have low effective therapies, right? So what are the high effective therapies? They are what, doctors? They are alemtuzumab, natalizumab, these ocrelizumab, right? These sumab, right? Maps, right? What are those? What? Yes, all sumabs. What, Dr. Rehan? What is the drug? Okay, we have disease modifying therapy, right? Disease modifying therapy. Under disease modifying therapy, what we have, doctors? What we have? These are the drug of choice under disease modifying therapy. Disease modifying therapy. Also, we have high efficacy drugs and low efficacy drug, right? High efficacy and low efficacy drugs, right? High efficacy and low efficacy drugs. So what are the high efficacy drugs? Because they are saying medicine question, and they have given these both drugs, and they are asking the treatment of this multiple sclerosis just uh, for the long term treatment, or sometimes they are asking as an initial treatment without giving an acute scenario. They can ask as the first line treatment. In that case, what you can choose, high efficacy or low efficacy drugs, doctors? Tell me. Dr. Bhagya, can you, if you can find it, please share that question. High efficacy drugs, right? Because that question has added recently. Because in previously in e-medicine, there was only one question for the these asking about this disease modifying therapy, and they have mentioned only this interferon beta 1 and other drugs from not from here, okay? And that case they have taken as the first line treatment as this interferon beta 1. But if they give these sumabs and these interferons and other things, both in same months, always go with high efficacy drugs, right? That as a alemtuzumab, natalizumab, like that. Okay, natalizumab, like that, doctors. Please remember. Okay, hope you understand this. What I am saying. Okay, then yeah. Then we have minute. Then let's see about. Okay. Okay. Mm, okay, then how we should treat multiple sclerosis relapses? How we should treat doctors multiple sclerosis relapses or acute exacerbation, like what else? How we should treat? Tell me. So here, moderate to severe inflammatory relapses usually have objective neurological signs and are treated with high dose corticosteroid. Therapy has recovery from the relapses and improve the clinical outcome in short term. And MS relapses can cause permanent disability. So it's important to recognize and treat moderate to severe relapses. So diagnosing relapses in patients with significant disability can be difficult if unable to confirm whether relapse has occurred. Refer to the neurologist's advice. So here for moderate to severe multiple sclerosis relapses in adults, the appropriate corticosteroid dose is methylprednisolone sodium succinate 1 gram intravenously over 30 minutes and daily 30 minutes daily for 3 days, right? Please remember. So please remember, doctors, okay, these things. Then how you should treat. Now tell me. Okay, then what else? In mild cases, I think they have mentioned something about in mild cases as well. Yeah, 1 minute there's mention about acute relapses again here. Because you need to know about that part as well. Right? I think they have changed it. Psychiatry, health, reproductive advice. No. Yeah, now just only this part. Hmm. Yeah, doctor, that's all. And now tell me how you should treat these patients with, okay, I'm asking them now one by one. If the patient presenting with fatigue, if the patient presenting with fatigue, then what is the treatment? What is the treatment? Because this patient can be presenting with fatigue. There's a question in emergency as well. So, what is the treatment of choice? Amantadine, right? Okay, this is the question, doctors. Dr. Bhagya has shared. We'll do this question. Okay, here. A 28-year-old woman, you can get an idea about this question. It's a very good question. 28-year-old woman present to the neurological clinic for review. Over the past 18 months, she has experienced three discrete neurological episodes, each of which has since resolved. Her first episode involved blurred vision and pain on eye movement in the right eye. 6 months later, she experienced numbness and tingling in her left arm. Most recently, she had double vision and shock like sensation on the neck flexion, which resolved 1 month ago. She has no other medical history and does not take any regular medications. On examination, she appears well with vital signs within normal limit. Her vision in right eye is mildly reduced with impaired color recognition. A relative afferent pupillary defect is present in the right eye, there is a no nystagmus and no cranial nerve palsy. The remainder of her neurological examination is unremarkable. The gadolinium enhanced MRI of the brain and spinal cord has shown multiple small non-enhanced lesion along the brain stem and three enhanced lesion along the cervical spinal cord. Which one of the following is the most appropriate next step in management? What do you think, doctors? Yes, good. Yeah, here. Okay. Here, in patient with relapsing remitting multiple sclerosis, high efficacy disease modifying therapy such as ocrelizumab is generally favored as first line treatment in Australia and New Zealand. Okay, so here interferon B also under DMT, right? But it is a low efficacy drug, right? It is a low efficacy drug, right? Low efficacy drug. But Dr. Bhagya, they have changed the answer again in last week. Previously, what was that? They have given another sumap. Ah, okay, okay. Yeah. I think we can find that in our recall files, right? I have added the screenshot of the question. Okay, yeah, yeah, that's a problem, doctor. In like before all of this before they have given only this interferon beta 1 and other drugs, okay, other drugs, and then they have taken interferon beta 1 as the first line. And in this yellow part also, they have mentioned this interferon beta 1 as the first line treatment. Okay. Okay, I have the proof. Okay, I'll share it. That's what I'm telling. Yeah, yeah. But in that question, this sumap was not there. Okay. And they have then anyway, interferon beta 1, we can go if there is a no sumap, right? But in the yellow part, they have mentioned interferon beta 1 as a first line treatment. Okay, otherwise they could have mentioned the interferon 1 beta 1 also first line, but it's a low efficacy drug, right? Always think about this sumap first, right? Yeah. The final thing you have to tell is always, yeah, anyway, sumap, right? Yeah, that's good. Yeah. Now it's ocrelizumab over alemtuzumab, right? Yeah, remember that part as well. Yeah, please, Sumab saves us. Yes, yes. Don't worry. If you get this question in the exam, you anyway mark the correct answer because we have taken so much time with this Sumab, right? Yeah. Okay. Okay. Yeah. I'll show that question as well, but don't confuse with it. Okay, these are the old question. When I was preparing for the exam, those are the question. There was only three question for this multiple sclerosis. It's multiple sclerosis. That's what. Now they have very updated, right? Okay, I think I have shared. 1 minute. You better wait. Okay, so here. Okay, I will delete it again, okay, because otherwise in your mind here. Okay, here that's the first option they have given in the long ago when I was doing here. Interferon beta 1 is the immunomodulatory molecule that responsible for this one. Then it is a first line agent in multiple sclerosis. Okay. Yeah. That's what I'm telling. Please remember this sumap. Okay, I'm gonna delete this. Okay, and yeah, here this is the question for the MRI. Okay, here MRI with gadolinium. So remember, just give it a read. But I'm gonna delete this part, okay? This interferon question, because some doctors are not joining the live class, and then if they see this one and they will confuse. So I don't want to make any confusion here. Right? Okay. So I'm gonna ask other questions as well. So now tell me, if the patient is presenting with spasticity, then what is the treatment? What is here, doctors? Okay, there's a question. Just 1 minute, we will discuss and let's see it later, okay? Doctor, can you share it in the group as well? Then you don't have to share it again. Please share this question in the group, then we all can have a look. So yeah, baclofen, right? Baclofen, then we have baclofen is the main one. Then we have clonazepam, diazepam as well. So remember baclofen, right? Then if the patient present in fatigue, you all know. Yeah, then yes. Yeah, the other drugs you all know, right? Like other cases they all mention in here. Here, baclofen, spasticity, and you have clonazepam, diazepam. Yeah, you can give it a read. I don't think they will ask questions other because they have so many things to ask here. Yes, yes, Dr. Bhagya, sexual dysfunction, sildenafil, right? Erectile dysfunction and everything. Then what else we have? Paroxysmal symptoms, carbamazepine, right? Fatigue, amantadine, bladder urgency, frequency. We can give oxybutylene, right? Yeah, that's all. Yeah, urine incontinence. We can give oxybutylene, right? I have mentioned here. Sexual difficulties. Yeah. Okay. Yes. Okay. Now we have 10 minutes and ALS. We don't have time to discuss ALS now. Okay, what is doctors? Oh, there's a question in the group. What is that? Let's discuss that part as well. So, 35 female with progressive vision loss on one side. Now, 3 out of 36. What test aid in assessing the prognosis of condition? Carotid duplex. Then they have given MRI. Okay, this VEP. Then albumin cytological dissociation in CSF. So, what do you think, doctors? Progressive vision loss one side. They have only discussed about this progressive vision loss, right, doctors? Like to diagnose it as multiple sclerosis, we need more details, right? At least like if it is presenting with optic neuritis, there should be what? Not only vision loss, right? There should be pain on eye movement, right? If they have mentioned pain on eye movement, then with this vision loss, we can think about multiple sclerosis and then we can go with MRI brain, right? MRI brain. But this only this progressive vision loss, I think we need more details in this question, right, doctors? What do you think? What about other doctors? So, what do you think about VEP, visual evoked potential? It can identify what? Identify this delay of nerve conduction, but here it's a progressive vision lost in one side. For me, I'm not marking anything for this question, doctors, because we need more details, right? Otherwise there's no point. Like if I mark something, like think like that, if they have given with this optic neuritis with painful eye movement and with this this vision loss. Then you can think about optic neuritis, and then you can think about multiple sclerosis, and then you have to do the MRI. Okay, MRI. Yeah, it's a progressive type, right? Yeah. Yeah, optic nerve conduction, we can do VEP, but here we need more details, doctors. Right? Yeah. Yes. Mm-hmm. Yeah. Okay. So I think we can finish today, and tomorrow we will discuss about ALS. Okay. And some few other topics as well. Hope everything is very clear and understandable, because asthma, COPD, pneumonia, very high yield topics, right? Very high yield, and please revise them. At least please try to do some MedC questions. Okay. And thank you so much. And like we can continue tomorrow as well. So let's see what we can do. Mm. Thank you so much, doctors. Yeah, so yeah, even though I'm telling I'm not uploading in the YouTube, don't worry, I will upload the same video, because I know some doctors have other commitment as well. Even though they have they have anyway, they have taken the holidays, right? Because exam is next week. So don't worry. I will upload this one in the YouTube, and then other doctors also can watch, right? Because actually, I told you that I'm not sharing, because actually the exam doctors, they need to actively participate, right? Otherwise, just not enough to watching the recording, right? Because you need to answer quickly, right? That that speech should be there while you are doing the exam, right? That's what I need to practice it, right? Otherwise, I'm just actually okay with sharing in YouTube or whatever. I don't mind, because anyway, I'm doing a help, so I don't mind. I need other doctors to join this class. Yeah. So yeah, doctors, thank you so much, and we'll meet tomorrow if we have time. Day after tomorrow also we will meet, but it's depend on you, right? Because I'm not taking too much time. Because yeah, yeah, sure, doctor, I'll share. Yeah, thank you so much, doctor. So we will meet tomorrow, and please study well. The same thing I'm telling every day. Eat well, sleep well, but not too much. Then study well. Okay, study well, because you have only 3 more days, right? 3 more days for your winning. Okay, don't be stressed. This is your winning week, right? This is your winning season, right? So think like that. Your everything will be paid off, right? So because of that, it, only 3 days you have to prove your dedication, prove your commitment, right? And make me proud as well, right? Yeah. Because I'm also doing classes and everything. So make me proud, right? Yeah. Yeah, yeah. Best of luck, doctors. Yeah. So study well. I'm not taking too much. Why, Dr. Ritik? Yeah. Why, Dr. Ritik? What happened? No, no, now you should be happy, right? You are at the end of this, right? You are at the end of the AMC journey. And after next week, you will be done with AMC, and right? Everything will be okay. So because of that, you will be happy, right? Not sad, not stressed. The only thing, though, these few days you have to do like more commitment, right? Just few, 3 or 4, like at least 5 days, right? You can do this. Yes, yes, that's what, right? Like imagine, like after doing exam, and you are going home with a relaxed heart, right? Even still, I'm getting goosebumps, right? Telling these things, because I feel the same. Yeah, in the November, because I did my exam in November, so I had the recent feeling. So yeah. I wish you all the best. You all can do this. Never attract negative energy. Always thinks I can. I can. Okay, there's no I can't. Oh no, I'm stressed. Don't even think about it. You can do this. Okay, it's a very doable exam. AMC is hard but doable exam, right? So please keep things in the mind. Yeah, it's okay, Dr. Abab. So yeah. I will share the recording as well. Don't worry. It's actually up to you, right? If you actually want to participate live. So anyway, you will join, right? Yeah. So don't worry, Dr. Abab, okay? Because actually I really need to actively participate of these March doctors, right? Yeah. Okay, so we'll meet tomorrow as well. We'll try to do like one more hour in tomorrow. So let's see how it's going. Thank you so much. Bye bye.